Good evening. Welcome to our Florida Firefighters Safety and Health Collaborative First Responder Family and Caregiver Connection this month. My name is Michelle Fayed. I'm the statewide coordinator for family services in Florida. I'm also a firefighter paramedic down here in South Florida. I can't begin to speak more highly of Alexandra. She has been just very kind to me in times of need and has an amazing program about talking to individuals about death, a very taboo subject. So with that, we will welcome her here this evening. I'm going to read a disclaimer and then let's hear about you, Alexandra, and start talking about the topic of the night.
All right.
The content of this presentation is proprietary and confidential information of the Florida Firefighters Safety and Health Collaborative. It is not intended to be distributed by any party without the written consent of the collaborative. Attendees should note that the educational component of this session is being recorded and will be published on the Florida Firefighters Safety and Health Collaborative's YouTube page. To maintain complete confidentiality, an announcement will be made before the recording begins, and only the presenter will be identified during the recording. Therefore, to ensure privacy, all attendees are asked to please mute their microphones until an announcement is made that the recording is complete. Presentations are intended for educational purposes only and do not replace independent professional judgment. The ideas expressed in this presentation are the professional opinion of the presenter and do not necessarily represent those of the Florida Firefighters Safety and Health Collaboratives or its constituents. Before acting on any of the information presented, attendees should consider the appropriateness of the information as it pertains to their individual situation and seek independent professional advice should any concerns arise. If you or anyone you know are in what is believed or perceived to be a situation that is or may become harmful, please reach out to the National Suicide Prevention Hotline via phone at 1-800-273-8255 or through their website, suicidepreventionhotline.org, or dial 911 in the event of an emergency. With that, once again, thank you so much, Alexandra, for joining us. We can't wait to hear about the wealth of information that you have about not just talking about death, but talking about death within first responder families, being that we see it almost every shift, right? It's not something that we're not exposed to regularly. We're excited to hear what you're going to give us this evening. So welcome, Alexandra. Thanks for being here.
Well, thank you. I really flattered that you'd reach out and want to put something like this on. I think it's really, really great. I mean, obviously, what a turnout. I know it's not early anywhere in the United States, so the fact that everybody's showed up, I definitely applaud that. For those of you who don't know me, a quick gist of what I'm doing here, where I come from a position to be able to talk to you guys about this. I'm a licensed paramedic. I've been in this field between serving my community as well as teaching for the last almost 19 years. I decided at some point to study grief, death, and bereavement for my master's degree with an intent of creating more conversation around death and first responders. That's what my focus was. Because the irony is, as much as we are around it, like Michelle said, daily, we don't talk about it at all, like for the most part, not in an educational space, not in a training space, and certainly not in the uncomfortable spaces outside of those really dark humor jokes that we usually reserve for, when we're alone at work, not at the dinner table with our families, right? So I've developed quite a bit of education around this. I've expanded the conversation with other professionals. You see Dr. Antebi's on here. He's definitely taken this and expanded it with his audience, which I really appreciate. And I would hope that at the end of this, you all do the same. Talking about it with either your family members or your crew or whoever it might be, taking this conversation to one other person is really just how it continues to grow. So I invite you to do that. The other thing is, and I love that we started off with the disclaimers and the privacy. I am big on that. I do not share people's names who kind of send stuff into me that I share with other people, and I usually ask permission before I do. But I do want to ask, if it's possible, I see a lot of people in uniform, which is great. How many of you guys, how many of the people on here are the family members of? So just kind of have an idea Okay, we got one. All right, that's Amy. Great. I just need like maybe even a guesstimate. Okay, we got a thumbs up right there. Okay, cool. So we do have a couple in here. And I would say that even though this was geared towards the families, I would imagine that those of you who are here have intentions of taking this back to your family. To be like, here's a way to kind of help. Here's a way to kind of, help me, deal with this when I go through it. So one of the things I want to challenge you all to do, regardless of what position you're coming in as, is ask yourself what your attitude towards death is. What is your comfortability with talking about your own mortality or the mortality of the people that are closest to you? And you don't have to answer that, but I really want you to think about it. Because as a society, we are a very death avoidant culture. Very death avoidant. Which is so ironic because we're very fascinated with it in like entertainment. Like we love that, the gory stuff keeps bringing some people back, not me. I had to take a few days off after the red wedding. Those of you who know what I'm talking about know what I'm talking about. The rest of you, I'm not going to spoil it for you. But yeah, that kind of entertainment, that's not something that really resonates with me as much as maybe I've seen some gory scenes on my own. But one thing I want to bring up is that it's very ironic that we would avoid something that we're all going to do. And what happens is that our own unconscious beliefs or our own fears or associations with it actually tend to show up in our interactions with other people. This is either with the way that you treat a patient on scene or the way that you speak to your family about it. I'll give you an example of something that happened with me. Was my mom had cancer most of my life. She had stage 4 cancer when I was maybe 4 years old. She wasn't expected to live then. She got cancer again when I was older. She had another emergency where she almost bled out. She was cancer free and very healthy the day that she died. Otherwise, the day that she died of a heart attack, and she didn't have any of her affairs in order. All those years had nothing in place for us. And it was her avoidance about wanting, like nobody could talk to her about death. She wouldn't acknowledge help that came in the form of palliative care, which if you know what palliative care is, it doesn't mean hospice, but that's what she associated it with. So she avoided it altogether. So when you acknowledge if you have kind of an aversion to it, that might tell you a thing or two about how you communicate with your family members when it comes to it, or how you communicate with yourself when it comes to a patient that dies. So what I'm going to focus on today is how the first responder reacts when a patient dies, what that might look like for the family member, and then what that family member can do to be more supportive if it is the case where this call just doesn't go to bed. This call just ruminates in their head. Maybe there's something about it that they can't get out of their head. Those are the kind of things that we're going to talk about today. And if there's anything outside of those topics, we can absolutely talk about them when we open it up. So one of the things that I think I've spoken to first responder significant others, and something that they're really surprised to hear is that sometimes nothing happens at all. I can't tell you how many times I have cleaned up the back of my bloody ambulance and not skipped a beat on what dinner was that night. Like, okay, what are we getting now? Like, I'm hungry. I've worked up an appetite. Nothing's going to ruin my appetite. And I actually had one gal come to me because she was concerned that her husband never got upset. And I had to assure her, you're not living with a sociopath, not necessarily anyways, but you're not living with a sociopath. Sometimes this is just our response to it. In fact, first responders are extremely good at compartmentalizing, meaning they can go do the gory stuff, clean up the blood, clean up the mess, deal with the patient that died, and then go home that night and have dinner with their family, or, stay the rest of the shift and get off the next morning. And there's absolutely nothing wrong with that. Okay. Now there are times where we compensate just fine, and there are times where we don't compensate, and that eventually comes out later. And what I mean by that is I had a friend reach out to me, started having nightmares, and he called. It was actually him and his wife called, because what he couldn't understand is life was good. Things were great. He was nearing retirement. They had gone on vacation, and all of a sudden he was having nightmares about 3 particular patients that died on him. that he hadn't thought about in over 20 years, that he thought were just fine, had no issues with it, and all of a sudden they're coming back. And that story, I can think of 4 other people that have had something similar. So they'll compensate until they don't. And there's really no way at the level that you're at, or, you know, being in a relationship with this person or having the same household as this person, to know which way it's going to go. Okay. You just kind of have to look out for it. And if that does happen to them, it's completely normal. It's just the body doing what it does, which is it's that it stores these memories. It stores any type of strong emotion, literally in the muscles, in the visceral tissue of our body. There's a really good book called The Body Keeps the Score. It focuses primarily on trauma. Okay. It focuses primarily on trauma and how PTSD actually resides in our bodies. Okay. But it's not just the trauma. It's any incredible dump of emotion, any significant event can all get stored in our body, but it all feels very intense. Okay. So that's a really good book I recommend for that. Now, the other thing I want to bring up is that, you know, with the exception of, let's say, a pediatric death or a very high profile case, something that got, you know, something real atypical, or something where maybe they spent a lot of time on scene with them. Maybe they spent a lot more time with the family afterwards. Maybe it's a line of duty death of a, there we go. That's Body Keeps the Score. Thank you. By James Kolk. There we go. Thank you. So with the exception of some of these really atypical complex calls, one thing that I like to tell the family members is that someone's worst day might be that first responder's best call. And that sounds real twisted for anybody who hasn't done this before, but if you're in this field, if you're in any medical field, there comes a point where you get burned out on doing nothing. Like all you're doing is the same old, like maybe you haven't started an IV, maybe you haven't given a medication, maybe you haven't felt your purpose show up. And then all of a sudden somebody's really horrific day happens. Maybe there's a cardiac arrest and you got the tube and you called every rhythm and you and your crew got every, you know, medication on board. Maybe that patient dies, but you felt really good about the interventions that you did. So sometimes there's this dopamine dump. Sometimes there's this like reward factor. And there was a researcher I spoke to recently who reached out because they were in the middle of doing some quantitative data on the effects of a first responder, EMS, after a patient dies. And so what they were doing was they were timing all these people, all these crews, basically after a patient dies, would it, their question was, would it take longer for them to respond in the next call? And what they found was not only did it not take longer, they were faster at responding for the next 5 shifts. And so this guy calls me, he's in public health, and he goes, I don't get it. He's like, there's all this talk about PTSD and depression and trauma and all this stuff. Why would they want to get there faster? And it was the first time I kind of explained to him, or he probably heard this, was that it's because it excites them. It's not that they're happy someone got hurt. It's that they feel fulfilled in their ability to help somebody and they got to actually do something. When it gets complicated is when there's an association between the first responder and the patient. So imagine I'm responding with a friend of mine that has a 3-year-old. A 3-year-old boy, a 3-year-old boy with blonde hair, a 3-year-old boy with blonde hair that loves to play in the pool every day that he's off. And we both respond to a 3-year-old drowning. Guess which one of us is going to have a harder time with that? It's automatically going to be the one that associates with it. That's not to say everybody's going to associate, okay? But a lot of times when a death gets to somebody, it's because they found just something of familiarity in them, whether it was the family around them or the patient itself or the circumstances, whatever it might be. One of mine was anytime a patient around my age died, that would get to me. And of course that would change with age. But I remember a call when a patient had, it was a car accident somewhere in kind of a little bit more of a remote area. And the boyfriend had died, but the girlfriend had lived, and she had to sit on the side of the road with him waiting for the first responders to get there. And she was our age. She was my age. She was my age and my boyfriend at the time's age. And for some reason that just stuck with me, and I can see where these things get lost, and, you can kind of continue down them. And so that'll cause the first responder, to ruminate on it. They're going to play the event over and over and over again in their head if this is something that affects them. Okay, so we're thinking worst case scenario, it's something that affects them. Some things that you might see is an ability or not, an effort to compensate. They're going to compensate for these things. You're going to see them pick up more shifts, or they're going to call off a bunch, and you're going to see their sick time drop or their vacation time drop. And they're going to avoid the area. They're going to avoid working. They're going to get busy with stuff at home. They're going to deflect with humor. They're going to numb with alcohol. They're going to do those kind of things. Okay. And this isn't even, I'm not trying to diagnose, nor am I trying to say that this is PTSD. This is just your regular stress response to certain things like this. Okay. Obviously, if it goes on a certain amount of time and there's other criteria, it could turn into that. But just because someone had a bad day and had a bad shift and had a bad call, that doesn't necessarily equate you're going to get PTSD either. Okay. In fact, and I wish I should have pulled it up before I got on here, there's some research that's suggesting that it's not the event itself, but the response to that event. Meaning, how did the providers, how did the organization respond to that person having to run that horrific call, kind of thing. So a lot of times it's the stuff that happens afterwards. So we talked about a couple of things, different things that might happen when a patient dies. We talked everything from absolutely nothing, compensate just fine, to they get stuck with them. They associate something with it and they ruminate over the event. Now, why it might affect them, obviously the association, but also another thing that might come up is failure. Now, this is something that I've observed, and that is that I suspect that when patients die, whether it gets to this point of bringing that call home with you or not, but when it comes to a patient dying, there is an unconscious association with failure. And that starts, and I will say this as an educator for the past 10 years, it starts in the classroom. Because if you've been through EMT or medic school, you remember, maybe you were like me and you were in you had similar teachers as I did, but we were told, if you don't remember this dose, if you don't remember your indications, if you don't remember your base hospital or your protocols, you're going to kill this patient. And that was a theme or something that just got told on repeat so many times that I caught myself doing it. And I thought, wait a minute, sometimes you can do everything right and the patient still dies. And I don't think we're reminded of that hardly enough. Okay. Burnout is definitely going to make it worse. Research has shown that the more death notifications that a first responder gives, that the higher their likelihood of burnout. So that can be an associated factor. Of course, somebody dying at work could affect the first responder, regardless of whether or not they were the ones giving the death notification. Just being there is enough. There could be an unfortunate, and I'm not going to put Michelle on the spot, but I think moral injury shows up here, and she did write a remarkable article about that for Firehouse World. I did see this happen with somebody when so where I last worked in the field, we were able to intubate pediatrics until about, I want to say 4 or 5 years ago. So it's been a few years. So when I was last working, we were still able to do it. And this medic that has been in the field for a very long time, that prides themselves on their skill and their ability to manage pediatric cardiac arrest, had a cardiac arrest. It was a traumatic pediatric cardiac arrest where the kid was ejected, and they got this child to the hospital. And what he couldn't get out of his head was that he didn't intubate her. He had the skill, he had the knowledge, he knew that this would have secured her airway, but instead she drowned in front of him. And it didn't matter that he didn't have the equipment. It didn't matter that it wasn't in his scope of practice anymore. But that still caused a degree of moral injury that definitely complicated his way of processing this child's death. I see Michelle shaking her head. So good. I hope you talk about that. The other thing that can affect the first responder when dealing with death is something called disenfranchised grief. This is something I learned about years after it actually occurred. This is something that I put 2 and 2 together when I was in my graduate program studying grief, when I went, oh, that's what happened to me. Because I remember being really upset over this 4-year-old kid on Easter that went into a, he had a mitral valve prolapse, if I remember correctly, mitral valve prolapse. So he kept going in and out of this dysrhythmia. Anyways, long story short, I remember getting so upset about it. I remember crying in the ambulance bay. And I remember thinking to myself, like, I don't have kids. Why am I upset about this? Like, this is supposed to be the thing that doesn't get to me. And I used to think, that's not my kid. Why am I upset? I don't even know this kid, right? Why am I so upset? What turns out is that not only is it common, albeit a rare occurrence, but not only is that rare occurrence common amongst all first responders and healthcare providers, including nurses and doctors, but it is so neglected to be talked about that it causes its own complicated type of grief. Disenfranchised grief. Disenfranchised grief is usually what you see when the most common example is a woman that suffers several miscarriages, and to her she's lost 4 or 5 children, but to the world she's never been a mother. So you see how that lack of acknowledgement for their right to grieve comes into play, and that can kind of be an association with this as well. Now, what to do? Okay, so those of you who are looking for some guidance on how to best support your first responder should a call like this follow them home. One of the best things you can do, especially following a very significant event, is let them sleep. Please let them sleep. Because now, if you've watched the movie Inside Out, if anybody has, even if you don't have kids, highly recommend it. It's great. If you can remember the scenes where the little workers are going in, and while they're sleeping, they're filing all the little balls. They're filing all the little memories. That is literally what our brain does. And when we go into REM, you hear the importance of REM and how little time we actually spend in REM. REM is actually filing all those events and all those thoughts away. So this is actually how the body auto processes the circumstance. And I will tell you that usually when I'm hearing from somebody who had a really bad call, that's in a bad place over it, it's at 5 a.m. because they've been up all night drinking. That person is not getting the sleep that they need to process this event. So if you have any influence on it, make them go take a safety nap, make them get to bed early, take a load off of them so that they can process that. The other thing to note is, are you living with an introvert or an extrovert? Some of the most social people I know are introverts. And I say this because most people associate social skill with introversion and extroversion, and that is not the case. Granted, our society is highly accommodating of the extroverts, me, but it's the introverts that have this real innate ability to process these things from just source that they receive within themselves. For me, I have to talk about something out loud to other people before I understand it. Whereas other people need quiet time with themselves. My partner needs quiet time with himself. And knowing that he's an introvert, I know that if he's had a day or if something's going on and I say, hey, is everything all right? Oh, X, Y, and Z, yes, but blah, blah. I know that's code for let him figure it out, and he'll come around. Sometimes it's later that day. Sometimes it's several days later and I already forgot about it because I've gone on to the next shiny thing. But you get what I'm saying is the point is that, people who process their emotions internally need to be respected of their boundary to do just that. It can feel very personal. It can feel like they're shutting you out, but that's really not the case. The other thing is if you are married to an extrovert or you have an extrovert in the family, A lot of times they want to vent. Okay. And maybe you've gotten in trouble for this. Maybe you've gotten mad about it yourself, but can you think of a time where someone came to you about something and you tried giving them solutions because you thought that's what we were doing here, and then they get mad at you because you weren't listening? I think every one of us have at least heard of that scenario or been in that scenario ourselves. Here's the trick. Venting is an opportunity to discover what the problem is. Okay, venting is an opportunity to discover what the problem is. And a lot of times, what that person who's opening up to you is trying to do is have their problem validated, whatever it might be. Okay, they just need their problem validated before they can even seek a solution. And a lot of times we skip that because we see the solution. We see that they just need to go, you just need to go see a therapist, or you just need to go talk to this person, or we need to call peer support, whatever it might be, but that's not where they're at yet. Okay, so we got to meet them where they're at, got to validate them in their pain. They need their pain validated. That is the intention of venting. And then we can move on. Also know that based on their temperament, they may just be processing versus shutting down. Okay, sometimes it's hard to tell the difference, especially, and only you would know. You would know if this person is normally an introvert, if this person normally comes to conclusions on their own, needs a little alone time to process it, versus shutting down. And what happens is in the brain so we could be exposed to a traumatic event, and that traumatic event may be unremarkable, but what it'll do, or what it might do, is trigger old traumatic events to come forward. Okay, so a lot of times one smaller thing will kind of uproot all the other stuff that's laying beneath the surface. Either way, if trauma is triggered in the brain, what will happen is sometimes the part of the brain that is responsible for creating language to something, to describing something with vocabulary, actually goes lights out. So when someone says, I don't want to talk about it, it might actually be they don't have the words to describe it. Keep that in mind, because a lot of times, so another thing is too, is our right and our left brains do not speak to each other very efficiently. They have a little bit of communication, but otherwise your right brain, to put it simplistically, stores the emotion of an experience, whereas the left brain houses the verbal ability to describe that. But if they don't talk to each other, they have a hard time opening up to you. That's where a lot of that comes from. Some other things you want to do is, if you feel the need to ask, don't hesitate to ask. Just honor whatever resistance you're getting, that maybe that's coming for a reason, that they need a little bit more time. But what you might be able to do is ask permission. Hey, can I ask you a question about this? And if they say no, okay, then you don't. But if they say yes, now they've given you consent to come in with a difficult question about that. Okay. Another thing I get told quite often is that first responders don't want to tell their family the details of something. And sometimes the family presses for it. And I think having an established boundary of what we're going to talk about and what we're not going to talk about before the incident actually occurs is really important. Because the family member might be curious and they might be interested, and they might feel that the only way to really support them is to know all the details. Whereas the first responder feels guilty because they're now exposing someone that they love and are trying to protect to the event that they're struggling to cope with themselves. So it's really a protective mechanism. And I think it's one that needs to be, that's one needs to be honored. I have a tendency, if I get reached out to about something and someone says, oh, it was the call here, I don't even ask them about the call. I just Google it. And I'm like, okay, I got enough information from this that I don't need to ask them more. Whatever, if what I'm reading in the news is this horrific and gut wrenching, I don't need them to revisit the parts that made it harder for them to actually be there, But yes, asking them permission to do that, letting them know you're here, not being offended if they don't want to open up about those things, because remember, it's not about shutting you out. It's about trying to, protect yourself and them. And then if kids are included here, so I know kids do get overlooked very often in the house. Kids are not dumb. I don't have them, but I remember being one very, very vividly. And kids understand what's going on. Now, that's not to say that you should include them on every conversation where mom or dad had a really hard call. But if they by chance hear it, or something is happening in the household that you just can't hide from them, to lie to them even further is actually more harming. They know what death is. I would say that there's different age groups that process death differently. All ages are considered able to grieve. You can grieve even as an infant, because usually if your caregivers can't, cadence gets thrown off, the infant follows. Kids under the age of 5 usually associate death with sleeping. But I would say that somewhere around the ages of 8 or 9, you really understand the finality of death and what that actually means. And I would say I probably remember more times I was lied to than not, and being very well aware of it and not feeling confident enough to call my parents out on it, but also keeping in the back of my mind, like, I knew what happened and you chose to lie about it instead. So include them as appropriate, but don't feel that hiding it from them when it can't be hidden is benefiting them at all. And I think really the last thing I want to kind of bring up is sometimes if they have a really bad call, if your first responder has a really bad call, their sadness could manifest is irritability, anger, short-temperedness. It's not always, when we think about someone who's sad or who's really upset over a call, it's not always this deflated person on the tailboard of an engine, thinking of like a Dan's son picture. A lot of times it can be. That's what's happening internally. That is what's happening internally, but on the outside, they're showing a completely different face. So letting them know that you're there, being willing to give them the space that they need. And if there's to a point where, let's say, call after call after call, or circumstances added to circumstances lead you to thinking that maybe therapy would be an appropriate intervention or something for them to do, be mindful not to push for or recommend something you're not willing to do as well. Because otherwise it makes them feel like I'm the odd one out. I'm the one that's broken. I had a family member come to me about their kid, and my number one recommendation about getting them into therapy was telling the parents to go to therapy too, not with them, but on their own. And it was hesitated at first, but it actually completely changed family dynamics this Christmas, to be completely honest with you, to see that happen. So if you want to get them out of the house for a walk, walking the dog, if you want to get them to the gym, if you want to get them to go, let's make a healthy dinner, let's, do a week of no alcohol, or a dry January, or whatever it might be, do it together. Because otherwise we're sending the message that you're the one that's wrong, you're the one that's broken, you're the one that needs to fix this, as opposed to we. And I think that if you ever run into a situation where you really think that your first responder could benefit from seeing a therapist and they just won't go, I'd ask yourself if you're going, because the best thing you can do to support a first responder, especially someone who could benefit from therapy, is to bring your own into that, because then that teaches you the boundaries that you need to set, the expectations, the realistic expectations of, and making sure you don't get wrapped up in what they're working through, and knowing what's yours and what's theirs and what you can do to be more supportive versus what they need out of you. At the end of the day, though, making sure that they have the support that they have. I don't want to put an excess amount of, like pressure or responsibility. But the support system that a first responder has at home has a massive impact on how they process the things that happen at work. I think we'll stop with that.
He's talking about what you just said. First of all, thanks for all the information that you gave us. Couldn't agree more on the importance of the role of family at home in the first responders' ability to help other people and to process what goes on. That's why we have these meetings. That's why we're currently in the process of building out curriculum with the University of Central Florida, and very excited about that. And, and really getting families involved in every aspect of understanding the challenges that first responders have and how you can help as the family member. So thanks for stressing that at the end, because we certainly couldn't agree more with it. I know Kelly O'Dare's on here and she hands down agrees with it too, because we're doing some work together. So that said, I also wanted to bring up the clinician part in the chat there, redlinerescue.org. Any state that you're in, give a look. You can upload peer supporters in there, and you can find a list of culturally competent clinicians as well. And if anyone needs more information on how to get a clinician registered in there, whatnot, you're welcome to reach out to myself or Mark, and we will happily give you more information. I want to open the floor before I have my list of follow-up questions. Remind everybody that we're still recording. And if anybody would like to ask during the recording questions, now's the time. And if not, we can turn off the recording and ask questions then. We'll wait to see. You did get a question in the chat box. Do you think that disenfranchised grief is more due to your own beliefs that you don't deserve to grieve about this thing, or the impressions and response of those around you not thinking you should be affected by that thing?
I think yes to both. I think it is more so the former. It is our association, because it's really nobody else was telling me that I didn't deserve to feel a certain way. And that's why I usually tell people that nobody disenfranchises the first responder, really any healthcare provider, more than that first responder or healthcare provider. We're the first to do it. Can it happen elsewhere? Yes. And can it happen almost implied? Yes, because I remember out of all the people that responded to this kid, I felt like the only one that was affected. And so I looked around and everybody's fine. And that can feel even more isolating. So I would say it's definitely both, but I have not heard it, the latter, as much as I have the former in people who have shared those experiences. But very good question.
Thanks so much for that. And then when you associate moral injury into the different aspects of that, silence is what it thrives on, and where you really start to develop high risk factors for suicide. So I'll fall on your heels and say, just talking to someone that you trust is the most, greatest gift of alleviation of burden that you can give yourself. They don't need to have the answers for you, but your ability to just speak to them about what you're feeling and not feel judged in return is epic. So
huge. And you reminded me of something that I forgot to mention, is that the obvious is yes, that you can be able to come home and talk to your family about what happened. But again, I think this is where the understanding of what boundaries are so important. I have a friend who the guy is just a magnet for trauma. I mean, we used to call him the Grim Reaper because of how many, of those types of calls. He really called himself that too. We weren't making fun of him, but he knew exactly what his wife could hear about, who was not in the field, and he knew exactly what she could not hear about. And when it came to those types of calls, and especially it was impactful when it was one of those calls that got to them, they came home and they didn't feel like they could talk to their wife, but because they had this agreement beforehand, he knew. He gets home and she's like, hey, so-and-so's garage is open, they're waiting for you, because she knew that there was a neighbor across the street that could talk to them about that, because they had a similar background and understanding of emergency stuff. So they could hear those details that he might have needed to get out as an extrovert, that his wife said, nope, I'm a mother now, I don't want to hear those things, but I know someone who does. Here's a beer, go hang out with them.
Yeah. All right. Thanks for sharing that. That's awesome to have that person. If anyone else has questions while we're recording and want to jump in, that's cool. If not, I'll start my quick follow-up questions here. The first one I'll say to you is, Jesse, do you have something? Nope, you turn off.
Yeah.
All right.
No, I do. Sorry, I was on mute. So my question is, do you have any? Could you point us to any examples or example conversations between a responder and their family, for those of us who might not know how to start those conversations?
No, it's a good question. So are you saying something like maybe they come home and you know that they had a bad call and you're kind of wanting, how do I bridge talking about it? And I think one of the best questions, I think nobody likes someone who's passive. We like very direct. We appreciate blunt. But I think also respecting that space and asking, hey, can I ask a question? Can we talk about what happened yesterday? Or are you ready to talk about it? Because I want you to know I'm here. What, in whatever capacity. So I think that was one of the best things I learned. I actually learned that in therapy, is ask permission to ask that difficult question, and then they're inviting you to come in with it, and it actually alleviates a little bit of anxiety on the person asking. But as far as like a scripted thing, that's probably the most scripted I feel comfortable getting with it, because I don't think that can go wrong. Yeah.
That's helpful.
Okay, good.
That was a really great question. Thank you so much. And Kelly said in the chat, we're working on curriculum right now to practice these conversations peer to peer amongst first responder families. So thanks so much for the response and for the question. I know that in this Zoom tonight, very grateful to not only have fire and police, but to have military represented as well. And so with that, I was married to someone in the Army. He lives with PTSD. And I know whenever, certain moments would happen, you could see that he wanted to get something off his chest, right? And it wouldn't come out. So in speaking to some of our, former service members in here, you're living with something you want to talk about, or your family member knows that there's something you want to get out. Is there a healthy way to talk about that old, trauma that they had been through, experiencing death and dying, or, what realm do you think that lives in?
That's a tough one, because by the time, so the irony, this is something I've been told with a few veterans I've worked with and the conversations I've had, there comes a point where they actually might miss it, which is the irony and the part that they have a hard time admitting to their family members. I've been told it's described as like a heavy weight. And it's this thing that people who are in homes with shift workers who are gone for maybe 48, 96 hours at a time, but eventually they come back. And so that shift and the weight they see them carrying is a little bit more subtle. And it's a little harder to identify than after coming home after 18 months or 6 months or whatever the deployment is. The most important thing to do, I think, when talking to anybody, and you'll hear that this is going to translate, whether it's military, whether it's a conversation with your mom, whether it's conversation with whoever you want to fill in the blank with, making sure that you're coming from a position of yourself. I feel like I am not, maybe, how am I able to support you more, as opposed to you're not listening to me, you don't care when I do this. You know what I mean? Like if you're really trying to take a position of this person is emotionally carrying a lot and I want to be the person that they come to, we also can't be the person that kind of attacks them for that behavior, while also having the discernment to hold a boundary of what is acceptable and what's not. Because getting blackout drunk when we have things to do, maybe dependents have to care about, we have to take care of, then obviously that has to be stopped. As far as how to open it up, be honest and direct. Tell them, this is something that you're curious about. This is something that you want to make sure that you're not missing an opportunity to support them. I think that's a big one, is how can I best support you? Asking them, because sometimes it's going to be just spend time with me. I know somebody, this crew had a really horrific call in their city, and one person went home to their wife and kids. Another person stayed at work because that's the way that they like they felt like they needed to continue working. Another person went home to their, spouse and kids as well. And then the other person went off duty, but stayed at work because they didn't have anywhere to go. They were going through divorce. So they're like, hey, we're going to keep you here, right? We're going to take care of you. And so that would be the biggest thing is, asking them, how can I best support you? And sometimes you're not going to like the answer, and we're going to have to be okay with that, because that's how you build trust. And that's how that trust is built, and that bridge is built over time. And one day they will open up. And you know what? I will tell you, I have had some very surprising conversations, and they will come out of nowhere. It's not going to be, let's sit down and talk about this. You're going to be out doing nothing remarkable, and all of a sudden floodgates are going to open up, and you're going to be like, I did not expect this. But it's building that trust to get to that point, I think, is what's most important.
Awesome. Thanks so much for that. I have, I guess, one more follow-up thought that maybe you can explain. I know, like you said, in medic school, and you and I have had this conversation before, right? You save everybody when you go through medic school. Everything's a save, great job. And we don't really prepare the early paramedic mind to say, you might do everything right, and it is just this individual's time, right? So I couldn't agree more with you on that. But there are some calls, the ones that bothered me in a very profound level, and I was hoping you can explain it. The death notification to a spouse that they've been married for like 60 years. So you're already like walking into a home of an older adult who, it's like a cultural thing. We take care of our older adults, right? And now here's this older adult and their loved one of forever just left, right? They passed away. I found those very, very, very difficult to deal with, more so than some other things that I had experienced. How do we, I guess it's a twofold question. How do we, early in our careers, how do I say this? How do you prepare your mind for things like that? Because I used to go outside and just cry a lot. And have to excuse myself. How do you prepare your mind for something that's not traumatic in nature with death? And then how do you, why is it that sometimes dealing with that kind of loss is so different than dealing with a traumatic loss, even of someone that, that's younger and, I'm trying to understand, I'm trying to contextualize this.
My first thought is what your association with an elderly couple is. Is it a grandparents? Is it parents? Is it somebody, if you come from a family that, I didn't know my mother's parents. I barely knew my father's parents before they died. But those who are raised very closely in the homes of their grandparents and maybe know what 60 years worth of marriage actually comes with, they're able to contemplate the magnitude of that loss. And I think that it's great to bring awareness to it, but to prepare in a sense of, and I know this isn't what you were saying, but in case anybody was thinking it, but to prepare in a sense of avoid or prevent would take away your superpower. That's where empathy comes in. That's where you versus someone else on scene is going to be able to show up better for that widow or widower the way someone else like me might not be able to. And that's where so many of us come in with so many different backgrounds. If I ran a call, oh man, I'm surprised I didn't get in more trouble for this because we weren't allowed to do it at the time. But if I had a cancer patient, they got all the narcs they wanted. What am I trying to prove here? You've got yes, you're on hospice, and yes, we're going to the hospital for something else, but to move you puts you in more pain. What do you want? I'll give it to you. And that was something some other people couldn't understand about me, but I didn't expect them to. So does that answer your question?
I think so.
It's interesting that I'm listening, and it feels very much like Michelle is equating having a difficult time dealing with that with weakness, where what's better, that or being the stoic crew that's that's in there not saying anything at all.
Is that correct?
I think I'm going to reword it and he'll get, I'm a wordy
Shocker.
person, shocker, right? I think that when I was very early in my career, I sympathized too much than empathized. And I think that was it's a big challenge early in the career, that when you're experiencing the death of someone, you take on the emotions with sympathy instead of standing there and saying, I empathize that this is difficult for you, but I can't
You're also
bear the
20
burden
years
of your
old.
feelings, huh?
You're also 20 years old.
I was also really young when that happened, but
Yeah.
I think
Well, I can tell you too that your definitions are correct, but the terms are backwards. You can sympathize with someone that keeps a good emotional distance. You empathize when you carry the weight of it. And empaths are, again, superpowers in our field, because not everybody has the ability to offer that. The problem is that empathy without boundaries leads to burnout, okay? Because they give so much, and then they don't get recharged. Now, the feeling and emotion with a specific type of patient, the association or the projection that you have from your experience onto the experience that you're watching is going to be so relative to different people. Sometimes it's going to be because of your, relationships that you had, or your experiences in life, or the fact that you have a kid that looks this age. And other times it's going to come out of nowhere where you're like, why the hell am I dealing with this? Or maybe it's the first time you've dealt with something to that degree. I mean, everybody, I think, remembers their first dead patient. Maybe I'm just me. Or maybe significant one. Anything that'll evoke an emotion, whether you can identify where it's coming from or not, is going to have a different impact. Okay. And on top of that, I think, a lot of times we do classes on compassion fatigue and empathy and all these, trying to be more compassion driven caregivers, but we don't talk about the importance of understanding that it's okay to acknowledge that a moment's happening. Like you can be upset about something, you can feel the pain in the room, you can feel the loss and the magnitude of their grief, and then it's there to be acknowledged and then let go of. Like you're there to acknowledge it so you know how to better show up for that person that you're comforting, and then it's time to release it. And we don't get taught that part either. We don't get taught that sometimes things are going to stick with us versus others. I mean, we don't even teach that we need to deliver death notifications, and that's a huge part of the job. So you can imagine where this stuff gets missed. But I think it's an absolutely great question to bring up. And I just think that bringing awareness as to what it is, where it's coming from, when it's beneficial to show up, and how we can kind of navigate it without trying to suppress it, because suppressing it won't do anything. Absolutely will not do anything. It'll just come up later in its own weird way, and it'll have its own pulse by then, and you'll really have no control over it.
and you bring up something I want to, and we're going to stop the recording here in a moment. First of all, again, thanks so much for being here. We're going to have some of this private conversation. I'd like to give you an opportunity to, first of all, tell people how they can reach you, and to give us like a quick, rundown of the death communications class that you have, which is amazing and and it's branching far outside first responders. It's well within reach price for people. Highly recommend it. Where can people find you and this amazing class that you offer, please?
Well, thank you. I would say my website's going to be emergencyresilience.com. The easiest way to get a hold of me on socials is going to be at Emergency Resilience. That's going to be for both Instagram and Facebook. I tend to be a lot more engaged on Instagram, as well as I'll put my name in here. Alexandra Jabr on LinkedIn is another option. And yes, if you go to the website, you will see a course. I have a few courses that I do, but only one of them is online. It is an online modular course, meaning it's been kind of pre-made. It's in its own LMS. You just go in, take the courses. It's not like a live event. A lot of people think it's a live event. And it's created by somebody that does not like online training. So I really did keep myself in mind as the student, as the target audience. And so I've heard that has been received very well. And death notifications or death communication is what I created as a way to approach death notifications from a very psychosocial lens, and just seeing things, understand the why behind it, and reflecting on our own discomfort with death along the way. And then there's a bonus module on occupational resilience with my good friend Ben. So
very grateful for that. I encourage everybody to look that up and take the opportunity to take that class. Thank you so much. Oh, the other thing I was going to say, I can totally vouch for the fact that she will get back to you. So she's not an unattainable or unreachable individual, amazing person and a kind soul. And for you, I'm very grateful. So thank you for this evening and for being with us. I'm going to stop the recording now, and we'll see everybody on our next recording next month. Thanks so much.